Good afternoon to one and all. I am Dr Samarpita Dhar presenting to you a case of pituitary macroadenoma. Pituitary adenomas are slow-growing and benign tumors of the anterior pituitary, which are classified on the basis of their size and functionality as functional, non-functional, and macro or microadenoma. Clinical features include mass effect like headache, vomiting, gradual and painless diminution of vision, color desaturation, etc. And diagnosis is based on endocrinological profile based on the various markers of pituitary and radiological investigations like CT and MRI. A 41-year-old female came to the ophthalmology OPD complaining of frequent changing of glasses in both eyes since 1 year and a diminution of vision which was gradual, painless and progressive in nature in the right eye since 3 months, followed by a dull aching headache in the bifrontal area since 3 months. There was no history of any trauma or nausea or vomiting. And she was a known case of hypothyroidism since 7 years and 1 year ago had an episode of irregular menstrual cycle based on which she was investigated and raised prolactin levels were found and physician consultation was done and she was given tablet cabergoline and was said to continue tablet thyroxine for hypothyroidism. On ocular examination, the vision in the right eye was 624, which was not improving, while in the left eye it was 66. Color vision was within normal limit and IOP was also within normal limit. The extraocular movements were full, free and painless in all cases, but the confrontation test showed a restriction in the both temporal fields. The anterior segment examination was within normal limit except and also the pupil was pupil showed direct and consensual light reflex to be present. The fundus examination in the left eye was within normal limit but on the right eye showed a temporal pallor. So based on the history and examination, a provisional diagnosis of bitemporal hemianopia was made and differential diagnosis included the optic chiasma disorders such as pituitary adenoma, which shows functional adenoma like abnormalities, and non-functional adenoma showed pressure symptoms. And in craniopharyngioma, it showed headache with focal neurological deficits and seizures, and AC aneurysm, which if ruptured shows the worst headache of life, and meningioma, which has features similar to the craniopharyngioma but has an extraaxial mass on dural attachment. Investigations were ocular. The ocular investigations were HVF24-2 and an optical coherence tomography. Systemic investigations showed a raised serum prolactin and a decreased serum cortisol. And the visual field showed a asymmetrical bitemporal hemianopia, and OCT RNFL showed a right eye RNFL segmental loss temporally, which coincided with the temporal pallor, and the macula OCT was within normal limit. Our suspicions were confirmed on MRI brain plus orbit, which showed a heterogeneously enhancing mass on axial MRI T1 weighted, which was 20 into 27 into 29 mm in size, and in parietal MRI, it showed a well-defined cellular and supracellular mass, which was all suggestive of pituitary macroadenoma. So based on this, a final diagnosis of bitemporal hemianopia secondary to pituitary macroadenoma, which was causing an optic chiasmal compression, was based on the confrontation test, visual field analysis, and MRI brain in orbit. So based on which an ophthalmological intervention was to refer to endocrinology, who suggested the continuation of tablet cabergoline, which was a dopamine agonist for control of hyperprolactinemia, and neurosurgical referral for transphenodal dissection of the tumor. So here we can see the patient following up in her OPD from October to November when transphenodal dissection of the pituitary adenoma was done, but unfortunately she was lost to follow-up. So the clinical implications suggest that advising MRI brain and visual field is extremely important, and an early diagnosis of mass defect is also important, and multidisciplinary approach, including an endocrinologist and neurosurgeon, is important. These are my literature review. Thank you so much.
What happens to the stereopsis in these patients with pituitary lesions?
Sorry, sir. Can you repeat the question?
No. Is the stereopsis likely to be affected or probably not?
Could be affected, sir.
Could be affected. That's why I said that if you know orthoptech, you will know the results. Where exactly is the fibers of stereopsis interconnected? Posterior corpus callosum.
Yes.
Much higher up and nothing to do with pituitary area. So they may have reduced vision, but stereopsis may still be absolutely normal. Okay, even if you cut the chiasma, they may have normal stereopsis. Okay?
Yes, sir.
So, any patient around the age of 40 who comes to you with frequent change of glasses, which he has never done in the past, particularly his presbyopia, is not happy with it, think of something else as the cause for his problems. Check his intraocular pressure, check his fundus carefully, and make sure that there are no other issues causing this problem. She had frequent change of glasses, right?
Yes, sir.
So there is no reason, unless you are a cataract surgeon, first thing you will do is remove the lens and say, okay, fine, go, everything is all right. Otherwise, you will check for specific things in any patient who complains of frequent change of glasses at 40.
Also, the blood sugar levels should be checked, because sometimes fluctuation in the blood sugar levels of a diabetic patient can also lead to this frequent change of the glasses. Okay.
Yes.
So I think this was a pretty straightforward case as such. Bitemporal hemianopia you found in confrontation itself. They found itself in the OPD in the confrontation that the patient had bitemporal hemianopia. So it was pretty straightforward and a well documented case. Thank you.
ma'am.
Now we'll
Anything
move
to
to the
ask?
next.
Have you done any other hormone assay?
Sir, serum prolactin levels were checked, which was found to be marginally raised, but it was not as raised as in functional adenomas. So we suspected that it was a non-functional adenoma, which was causing a compression on the pituitary stalk, thus decreasing the dopamine levels, which has an inhibitory effect on prolactin.